So good afternoon, everyone. I just would like to welcome everyone, including our friends from St. George's Medical School for today's OC3PR from Critical Care Services, Ontario. I suspect many of you will be looking forward to it as we'll be discussing a problem that I too have had actually many questions on. I will be exploring the issues surrounding blood coagulation in COVID-19 patients. As always, some things to remember for today's webinar. If you have a question, please send it to Q&A and we'll do our best to get it asked, time permitting, recognizing that this is our last time with this enhanced webinar format, barring a gracious gift from someone out there. Today's Q&A are being fielded by Dr. Josée Thériault and our today's co-host, the esteemed leader of OC3PR, and a proud new grandfather, Dr. Michael Sullivan. As always, we would appreciate if you do your best to keep yourself muted. We encourage everyone to follow CCSO on YouTube and Twitter and to visit the website. We truly value you taking the time to fill out the evaluation survey at the end, as it truly does help us refine our future webinars. We really appreciate you doing that survey, and we also want your comments and suggestions, so please send them to info@ccso.ca. We've been reading them and we're doing our best to act on the suggestions and questions. We are also presently formulating a response to the previous webinar on the emergency standard of care, where we received almost 100 questions or comments. So look for that coming soon, a response to that webinar. As alluded earlier, today's topic is certainly one I'm quite interested in hearing more about. Early on in COVID pandemic, we were hearing lots of reports of hypercoagulable issues occurring. I recall a colleague telling me how often they were having difficulty dialyzing some of their COVID patients due to the fact that the circuits were frequently getting blocked with clots and going down. It was quite evident early on that coagulation issues were going to have a significant role in COVID-19 patients. I even opined as well whether or not activated protein C, the much hyped but now long gone medication from years ago, would have potentially had a role. Rightly or wrongly, I now follow D-dimers in my COVID patients, a blood test that I previously put very little value in my ICU patients. Thus, I'll be interested in hearing what I should really be doing from today's speaker, Dr. Lana Castellucci. Dr. Castellucci is a thrombosis specialist and assistant professor in medicine at the University of Ottawa. She's also a scientist at the Ottawa Hospital Research Institute with interest focusing on the prevention and management of anticoagulant-related bleeding. She is on the ISTH World Thrombosis Day Steering Committee and sits on the board of directors of Thrombosis Canada. She's an active member of the Canadian Venous Thromboembolism Clinical Trials and Outcome Research Network, which is a lot easier just to call CAN-VECTOR. She's been the recipient of many awards and has participated in many studies, including those on COVID-19. Today's objectives are to help us understand what is currently known about the pathophysiology of coagulation in COVID-19, to better understand the clinical manifestations of its coagulation abnormalities, and finally, to describe anticoagulation strategies for our COVID-19 patients. Although these objectives are ambitious, I have full confidence in Dr. Castellucci's ability to deliver on them, as well as to help bring clarity on this confusing area of care for COVID patients. Lana, thank you again for taking the time to do this, and I do look forward to hearing your presentation.
Great, thanks for having me today this afternoon, Dave and Mike. It's a pleasure to be here, and I am very much looking forward to discussing some great work. So we'll talk about thrombosis and COVID-19. And as Dave mentioned, we'll look at the mechanism of coagulopathy, some of the clinical manifestations of that coagulopathy. And importantly, we will talk about thromboprophylaxis strategies for these patients with COVID-19, with a special focus on the ATTACK trial results, the ACTIV-4A and REMAP-CAP multi-platform trial interim analysis results. Please note that all of the results I'm going to talk about today are pre-publication, and they are not from locked databases and have not yet been peer reviewed. And the results were released on January 28th. So some of you may have previously seen what I will present this afternoon. So as everybody knows, COVID-19 is severe acute respiratory syndrome, coronavirus 2 as the cause, and it's an RNA virus belonging to the same genus that caused SARS epidemic back in 2002, 2003. Two websites that I particularly like to look at for the epidemiology of COVID-19. Sorry, I'm in the hospital. So two of these websites that I like are the WHO website, and in particular, this last website from Johns Hopkins University. This is a worldwide snapshot of COVID-19 data, and down in the bottom left here, you'll see this is from World Thrombosis Day, October 13th. So at that time, there were 38 million cases globally and a little over 1 million cases of death attributed to COVID-19. This morning, I went back to this website, and what you can see is that the global cases has more than tripled, and the number of deaths attributed to COVID-19 has more than doubled at nearly 2.5 million. So as you can see also from this global map here, the areas that were hardest hit very early on in the pandemic continue to be very dramatically affected by the pandemic. And you can see up here in Canada that we have our typical big cities that are involved. So what do we know about the coagulopathy that's caused by SARS-CoV-2? We know that the virus shown here in the upper left of the figure, that it uses its spike glycoprotein on the envelope to bind to the ACE2 receptor. And the ACE2 receptor is ubiquitous in the body, found in organs such as the heart, lung, brain, kidney, and the endothelium. And it's those areas, those organs that we are often seeing the thrombotic complications. And it's because that's where these ACE2 receptors are located. So once that glycoprotein binds to the receptor, what happens is this huge inflammatory response that leads to endothelial injury and inflammation with an inflammatory response activating the immune system. And so on the right-hand side here, what you start to see is activation of the coagulation cascade with thrombin formation, fibrin deposition, and really what we're talking about is thrombus formation. And the purpose of today's talk is to really look at use of anticoagulation to interrupt this process and prevent thrombosis from forming. So the COVID-19 virus, as you know, has varying disease severity, and most patients are asymptomatic with minor infectious symptoms that are flu-like, and they last 7 to 10 days. But the disease can become more severe, and 10 to 15% of symptomatic patients will need to be admitted to hospital. And about 20% of those 15% of patients admitted to hospital will need care in the ICU. And really, we're talking about those patients that develop COVID-19 pneumonia with a huge inflammatory response and a cytokine storm, which results in macrophage activation and what we call the COVID coagulopathy. Part of that coagulopathy includes an elevated D-dimer, and we'll talk about that in a few slides. On the bottom right here is a CT scan slice of what we've become pathognomonic of COVID-19 pneumonia with the ground glass opacities in the periphery and the basal levels of the lungs. As with the severity of COVID-19 infection, the risk of VTE also changes. So what this slide is showing is that infection here on the far left happens, and when patients are still at home, we think that their VTE risk, because of the inflammation of COVID, starts to increase. But really what happens is once they hit the hospitalized setting, shown here in the middle with the red bar and this red hill, if you will, what we see is that these patients have increased risk of thrombosis once they hit the hospital. Early on from China and Europe, we learned that patients admitted to the hospital wards had risk of VTE of about 5%, and that's despite DVT prophylaxis being used. And more importantly, in the ICU population, we saw that up to 30% of patients were developing VTE. And again, this is despite use of DVT prophylaxis at standard dosing. So what happens after they leave hospital is also an increased risk of thrombosis. So we consider this probably moderate risk. And there are ongoing studies looking at anticoagulation and antiplatelet strategies, both pre-hospitalization and post-discharge. Next, we're going to talk about what manifestations of thrombosis we see with COVID-19 infection. So many of you know that we see both venous and arterial events. And in the venous side, it's mainly deep vein thrombosis of the lower extremities and pulmonary embolism. Many of the PEs that have been identified are not necessarily embolic, but rather pulmonary embolism in situ, meaning that there's no concurrent deep vein thrombosis seen with it. And on the arterial side, we see MIs and strokes. Another big factor to the coagulopathy that we've recognized is microthrombosis is a big contributor to organ dysfunction and morbidity and mortality. Getting back to the D-dimer, we know that it is elevated and it's associated both with increased risk of thrombosis, but also with increased risk of death in COVID-19. The International Society of Thrombosis and Hemostasis recommends measuring the D-dimer, and I recommend trending the D-dimer in hospitalized patients because I do see value in that. It's unknown if the D-dimer levels should impact anticoagulation strategies used, and that's part of what we'll discuss when we look at the results in a little bit. Some of the other important biomarkers that have been included and recognized as part of the coagulopathy include a mild thrombocytopenia, but we don't know what its clinical significance is. And this is really very mild. Usually patients have a platelet count of 100 to 150. Many patients will have lymphopenia, as with other viral infections, and some patients will have mild prolongation of the PT. As I mentioned, the D-dimer, when very elevated at 4 to 6 times the upper limit of normal, is prognostic and associated with increased risk of mortality. And as many of you also know, the fibrinogen is often very elevated until late in the disease, and we can see elevations up to 10 or 14 days after infection. So where I work at the Ottawa Hospital, my group looked at these data coming from Europe and China with very high VTE rates in hospitalized patients. And we questioned whether or not our standard DVT prophylaxis strategy was sufficient. And we looked at the elevated D-dimer levels as well, and we knew that it was associated both with disease severity and mortality. And we elected to increase our DVT prophylaxis strategy for patients admitted to hospital with COVID-19. And we implemented a weight-based strategy using intermediate dosing of enoxaparin 0.5 milligrams per kilogram twice a day or every 12 hours. And we used this only during hospitalization for the duration of the acute illness. And then use of therapeutic low molecular weight heparin was restricted to clinical trials. However, some of our ICU patients, because of their severity of illness, some did receive IV unfractionated heparin. We also know from some observational data early in the pandemic, in particular from New York, that looked at 2,800 patients, that therapeutic anticoagulation was associated with increased survival. And the longer you used anticoagulation, the lower the mortality that was seen, in particular in mechanically ventilated patients in the ICU. And importantly, they also looked at major bleeding event rates. And on therapeutic anticoagulation, that was reported at about 3%. Compared to 2% for patients that receive standard VTE prophylaxis dosing. There are a lot of limitations to these observational data, in particular survivor bias and confounding by indication. And there are many other smaller studies that similarly report cohort data or observational data where benefits are seen with the anticoagulants, but it's weak data. And so we don't know really how to apply that to our patients. With all of that information, many different groups started to look at randomized controlled trials comparing therapeutic dose of heparin to standard of care heparin. And this is a table showing 20 different clinical trials that are currently running. I've highlighted 2 that are led by Canadians. So RAPID is led by Michelle Scholzberg in Toronto, and the ATTACK trial by Ryan Zaranchansky from Winnipeg in Manitoba. And these are 2 studies that we participated in at my institution in Ottawa. We'll talk next about the ATTACK trial because that's what we're really highlighting for today's discussion. And the ATTACK trial is based on the premise that using therapeutic anticoagulation improves clinical outcomes in patients admitted to hospital with COVID-19. And these are patients that are considered moderately ill and not in the intensive care unit. What happened early on with several of these trial platforms. So the ATTACK trial platform, REMAP CAP, and Active 4A, they joined forces to create this multi-platform RCT. And they did that really to try and harmonize all of the information so that we can answer a question as quickly as possible. ATTACK, as I mentioned, is led by a group of Canadians, and it involved 58 sites across Canada, US, Brazil, and Mexico. And the other details for these trials and their platforms are listed here, with many other sites internationally. So these three different groups harmonized their protocols, and they also came up with common primary and key secondary and safety outcomes. And they did this, as I said, to try and answer this question of whether or not using therapeutic anticoagulation benefits patients admitted to hospital with COVID-19. And importantly, they also looked at superiority and futility rules, and they specified these a priori so that we had clear instructions of when it was important to stop or change our management for patients. A little bit more about the multi-platform RCT. So we know that it's randomized, open label, adaptive Bayesian trial, and patients that were included were adults admitted to hospital with COVID-19, and they were randomized within 3 days of admission to hospital or 2 days for REMAP CAP in the ICU population. And the intervention is therapeutic low molecular weight heparin or unfractionated heparin IV. And the control group was usual care anticoagulation. And this is important to highlight because each center had a different anticoagulation strategy that they were using for VTE prophylaxis for this cohort. So as I mentioned earlier, in my institution, we adopted an intermediate weight-based protocol. Many others use standard dosing of VTE prophylaxis. So that's important to keep in mind, and we'll talk a little bit about that during the results. And the duration of treatment with either treatment dose of heparin or prophylactic dose was for 14 days or until hospital discharge. And specifically to the ATTACK trial was free of supplemental oxygen if it was needed, and whichever one of these occurred first. So as I mentioned, these three trials harmonized their primary outcome, and they came up with an outcome called organ support-free days up to day 21. And this is an ordinal scale that combines in-hospital mortality and organ support-free days, again, looking from day 0 all the way to day 21. And mortality, of course, is assigned the worst score of -1. And they also had a composite measuring clinically relevant morbidity and mortality. And you're asking yourself, what are the organ support measures that we're talking about? And at the bottom here, what we're talking about are patients requiring ICU level of care and receiving mechanical ventilation, vasopressors, ECMO, or high flow nasal cannula. Secondary outcomes were around the idea of safety. So major bleeding according to the ISTH criteria and heparin-induced thrombocytopenia. And other efficacy secondary outcomes included mortality, need for intubation, major thrombosis, which included DVT, pulmonary embolism, stroke, MI, as well as length of stay both in hospital and in the intensive care unit. And as I mentioned previously, a brief note about the analysis. So a priori, they stratified patients according to severity of illness. So they had a group for critically ill patients and then a group for moderately ill patients, with the difference being need for ICU level care or not. And again, in the moderately ill group, they further stratified them according to D-dimer level at the time of randomization. So there was the high D-dimer category, which was at least 2 times the upper limit of normal, the low D-dimer, which was less than 2 times the upper limit of normal. And then there was also a group of patients that did not have D-dimers measured at baseline. Next, we'll move into the important eligibility criteria. So I mentioned they were adult patients positive for COVID-19 and expected to be in hospital for at least 3 days. This is a very busy slide, but it's an important slide highlighting the really critical exclusion criteria for these patients. The ones that I think are most important are obviously patients who are actively bleeding were not included, patients with coagulopathy with thrombocytopenia that was severe with counts less than 50, INRs above 2 that was not related to use of an anticoagulant, as well as current use of dual antiplatelet therapy. So any patient that was on dual antiplatelets was not eligible. On the right-hand side, you will see another list of risk factors for bleeding, and many of these are the same risk factors that we look for eligibility for receiving systemic thrombolysis for things like ischemic stroke. So they're all very similar. So history of intracranial bleeding, history of intracranial cancers, etc. You will have access to this after the talk, so you can peruse this information, which is important when selecting your patient for therapeutic anticoagulation. Again, looking at the decision rules that were established a priori from the multi-platform RCT. So they decided to declare superiority of greater than 99% posterior probability of superiority on the primary outcome with a proportional odds ratio greater than 1. And futility was met if less than 5% posterior probability of at least 20% improvement for the primary outcome was met with an odds ratio of greater than 1.2. And again, they looked at these decision rules according to the D-dimer strata for the moderately ill population. Many of you will remember seeing this notice back in December 2020 that all DSMBs had met independently and reviewed the data from each trial platform, and each had recommended that for critically ill patients admitted to the ICU and receiving organ support therapy, that patients stop receiving therapeutic anticoagulation because this pre-specified stopping boundary for futility had been met. And so this was very much an important game-changing notification that was received in December. And all patients who were currently receiving therapeutic anticoagulation in the trial stopped receiving therapeutic dosing, were dropped down to intermediate or prophylactic dosing according to each institution, and follow-up continued as per the trial protocols. Similarly, about a month later, on January 21st, we had another notification that for the moderately ill patient populations admitted to hospital but not in the ICU, that again, each DSMB had met and reviewed the data from each trial platform. And again, what they recommended was that superiority had been met. And this time, what they found was that therapeutic anticoagulation was beneficial to this patient cohort. And this was achieved in both D-dimer strata, so the low group and the high group. And the safety profile supported the benefit of therapeutic anticoagulation in this patient population. So this is really exciting, very much game-changing data that many institutions have already started to implement. And next, I'm going to get into the details of the results that we have so far. And again, I will remind you that we don't have all of the final analysis yet because we are still completing follow-up for patients. So this information is what is available as of early January. There is more information to come, and hopefully more information on the subgroups where we all have many questions about this patient population. So what you will see here on the left-hand side, there are 4 different platforms that were included in this interim analysis. So the ATTACK trial, Active 4A, PROTECT is the pilot study for Active 4A, and then REMAP CAP. And in total, randomized as of January 21st was nearly 2,900 patients. And as of January 21st, we had information up to day 21 on organ support-free days for nearly 2,300 patients. Moving on to some of the baseline demographics for the moderately ill cohort as of January 4th, we can see here the baseline age groups are according to decade, and mainly this group was of age 50 to 70. So these 2 middle bars make up the bulk of the patient population. And on the right-hand side, sex at birth, we're not surprised to see that males make up the majority of patients participating, as we know that the male sex is most afflicted by COVID-19. The dark shading that you see in both of these diagrams represents the patient population that has reached the 21-day organ support-free day outcome, so that we have that information. Similarly, when we look at the severely ill population, again, the age groups here on the left, and again, 50s to, I would say, 80s in this strata, and sex at birth, again, predominance of males, with the dark shaded portion, again, demonstrating that we've reached the 21 days for known organ support-free outcomes. This is the fun part. So we're going to get to the information about our primary outcome and look at first down here, the severe state, so this critically ill population. What we saw here is that the proportional odds ratio is less than 1.76, and this met futility. And this is why the information was shared in December, and it was recommended that critically ill patients not receive therapeutic anticoagulation. Next, we'll talk about the moderately ill arms, and it's broken down according to D-dimer threshold. What you can see for all of them is that the proportional odds ratio is around 1.5. And for both the low D-dimer group and the high D-dimer group, this met superiority. So what we know is that the D-dimer is not helpful in distinguishing which patients benefit from therapeutic anticoagulation. And when you group them all together, a benefit is seen to using therapeutic anticoagulation in this moderately ill population of COVID-19 patients. This is a very busy slide, and it represents organ support-free days. Up here at the very top is the ordinal scale that we're talking about, with the orange representing death and all the way down to 2021 in the blue representing organ support-free days. These are couples, and so each couple is a different strata. So the first couple is the moderate straight with high D-dimer. The next is the moderate state, low D-dimer, moderate state, missing D-dimer, and then at the very bottom couple is the severe state. The top line in each couple represents those that received thromboprophylaxis dosing, and the bottom line represents therapeutic anticoagulation. So I'll take you first through the high D-dimer moderately ill group. What you see in the thromboprophylaxis arm is that at day 21, 25% of patients required organ support compared to 18% receiving therapeutic dose anticoagulation. Similarly, in the low D-dimer group, those receiving prophylaxis doses of anticoagulation, 19% required organ support at day 21, compared to 13% in the therapeutic anticoagulation arm. When we put all of this information together and we group all of these moderately ill cohorts, regardless of D-dimer state, what we see at day 21 is those receiving prophylactic anticoagulation, 23% required organ support compared to 16% at day 21. And so this is a very significant difference. And this is why the recommendation was to stop recruitment and that patients meeting the eligibility criteria receive therapeutic dose anticoagulation. So next we'll move on to some of the other outcomes that are important and that we all want to know about. So mortality. I'll remind you again that mortality itself was not the primary outcome, and it is part of the organ support-free days outcomes that were measured. And what you see here in the moderate state is that 5.7% receiving therapeutic anticoagulation died, compared to 7.7% in the prophylaxis anticoagulation arm. So an absolute difference of 2%. In the severe state, those receiving therapeutic anticoagulation, 35% died compared to 32.5% in the group receiving prophylaxis anticoagulation. So again, important differences that were seen and contributed to why that recommendation was made to stop recruitment. We'll talk next about the safety outcomes. So major bleeding was defined by the ISTH criteria. And please keep in mind that these outcome results are reported based on preliminary data that has not yet been adjudicated. And so there is some reporting bias that may be evident. Major bleeding in the moderately ill state, in those receiving therapeutic anticoagulation, the rate was 1.6% compared to those on prophylactic dose anticoagulation at just under 1%. And in the severely ill population in the ICU, 3.7% had bleeding events on therapeutic anticoagulation compared to 1.8%. And if you remember from the observational data that I presented earlier, we saw that it was about 2% in the prophylaxis arm compared to 3% in the therapeutic arm. So this data and these bleeding event rates are very similar to what was anticipated from that early observational data. Next, we want to know about thrombotic events. Are we actually preventing blood clots from forming? In the moderately ill group receiving therapeutic anticoagulation, just under 2% had thrombotic events, which were a combination of DVT, PE, MI, and stroke. And that's compared to 3.2% in the moderately ill group that was receiving DVT prophylaxis. And again, in the severely ill ICU population, 6.7% in the therapeutic anticoagulation arm had thrombotic events compared to nearly 12% receiving prophylaxis dosing of anticoagulation. And again, this information is presented very preliminary with unadjudicated results. So what do we know from this information so far? So as I mentioned earlier, on January 21st, this interim conclusion was met. Moderately ill patients with COVID-19 admitted to hospital but not requiring ICU organ support, that therapeutic dose anticoagulation was superior to usual anticoagulation prophylaxis strategies regarding organ support-free days in both D-dimer strata. And the positive effect was seen across morbidity and mortality components of the primary endpoint. And very reassuring was that those that did receive therapeutic anticoagulation had major bleeding event rates of less than 2%. Similarly, back in December, we learned about the ICU population, that if you are severely ill, therapeutic anticoagulation does not improve your organ support-free days to day 21, and the likelihood that therapeutic anticoagulation is inferior or harmful was met compared to usual care at nearly 99%. And again, although there was an increase in major bleeding events and mortality in this severely ill strata, the major bleeding event rates were very similar to what was predicted at approximately 3%. So next we'll move on to some of our frequently asked questions that I often get when presenting this information. So who should get therapeutic anticoagulation? And again, we want to refer back to the eligibility criteria for the ATTACK trial. So patients with COVID pneumonia admitted to a hospital ward. With respect to oxygen use, patients needing oxygen and not needing oxygen were eligible for the study. So that is not a requirement to give your patient therapeutic anticoagulation. And I would ask that you review eligibility criteria because we want to make sure that patients are not at increased bleeding risk and that we're appropriately selecting patients. Patients with renal failure and those requiring dialysis were eligible, and those patients received IV unfractionated heparin. And I would suggest that if patients are not receiving therapeutic anticoagulation, that consideration for intermediate dose DVT prophylaxis be used, such as the one in our institution of enoxaparin 0.5 milligrams per kilogram Q12H. The length of treatment for patients is up to 14 days, or when they're off oxygen, as in the ATTACK trial, if they required it, or if they are transferred to a regular hospital ward. And what we suggest at that point in time is that when all of this is met, you reduce the dose to standard DVT prophylaxis and not an intermediate dose that's used, such as in my institution. How do we reduce bleeding risks? So as I mentioned, patients on dual antiplatelets were not eligible for the study. However, we did have many patients on single antiplatelet agents. And I would ask that you consider stopping their antiplatelet agent while on anticoagulation, if that's possible, and to remember to restart it once the therapeutic anticoagulation is stopped, if it's appropriate to do so. And to reduce risk of GI bleeding, also add in a PPI, because these patients are also often on dexamethasone, and so that combination increases their risk of GI bleeds. The next question is, what do we do with patients that deteriorate and they're initially in a hospital ward that's designated as your COVID area, and now they deteriorate and they need to be transferred to the ICU? We don't really know what to do about this population. The ATTACK trial did include this population, and they recommended treatment continue when patients became critically ill. What we know from the interim analysis so far is that when this group of patients was included with the other group of patients that did not require transfer to ICU, an overall benefit was seen. And the subgroup analysis is pending, and so we will have more of that information available in the months to come. So the current recommendation from the ATTACK trial team is to continue therapeutic anticoagulation once patients are transferred to the ICU as per the protocol. But of course, this is up to the treating physicians and with assessment of bleeding risk. And next, what do you do when patients improve from the ICU and they're downgraded to your COVID ward or regular hospital ward? Again, we don't have as much information about this patient population, and more information will be coming from the REMAP-CAP study. What we are recommending is that you continue the anticoagulation prophylaxis used in the ICU upon transfer to a hospital ward. And I would like to finish by acknowledging our patients and their family members who participated in all of our COVID clinical trials, in particular the ATTACK and RAPID trials, so that we have this information. And of course, to our ATTACK trial research teams, because this was a huge undertaking with an international collaboration. And so I would like to acknowledge everybody's efforts. So thank you very much. And I will take any questions that people have.
Thank you, Lana. Fantastic presentation. Certainly, I think we have several questions. If you're all right, I'm going to start off with some of my own here.
Sure.
I was wondering about, the intermediate. Let's assume I have two patients, both on your intermediate dosing of enoxaparin, and their D dimers are already more than 2 times the upper limit. Let's say one of them is not getting better, but the D dimers are rising. What would you suggest that I do in that setting? And a very similar second patient who is also got similar D dimers that are rising on the same dose of enoxaparin, who is actually getting worse and the D dimers are rising. So one's not getting better, but they're rising, and the other is they're rising and getting worse. Would you recommend any changes, or how would you approach that?
Yeah, absolutely. Thank you for that. So that's where I do think that trending the D dimers is helpful. So not only measuring them, but trending them, because I do think that when you see a rising D dimer in conjunction with a patient that's deteriorating from a respiratory perspective, I do think that is an important step to say, okay, maybe they do have a pulmonary embolism, and getting imaging to confirm that, I think, would be important. Early on in the pandemic, everybody was afraid of transferring patients within the hospital to go and get imaging, but I think we've all worked out strategies to safely do that. So I think the ability to get imaging is a lot easier now. And so I think it's reasonable to get the imaging. And if you can't get the imaging in a timely fashion, but you can get it, say, in the next few hours, reasonable to give a dose of therapeutic anticoagulation while you're waiting for that imaging to confirm presence of a PE. And in the cohorts where their D dimer is rising, but you're not seeing a clinical change, again, I think it's reasonable to hold the course and monitor them. But if you do have suspicion, then send them for imaging and see if you can confirm that PE diagnosis.
Thanks, Lana. Josée, do you have some questions to ask?
Yes, thank you. Thank you very much for this excellent presentation. Yes, we have some questions actually that are similar, and I think it relates to the different levels of ICU across the province.
Yes.
And, criteria for certain areas where resources are different and support. So how would you define patients that are presenting are admitted to ICU on oxygen? What would be the cutoff, or looking at the high flow nasal cannula, what would you consider ICU and not ICU?
Yeah, that's a really great question. So here in Ottawa, in our institution, many of our patients on the COVID ward are on high flow nasal cannula. And so they would be receiving ICU level of care, if you will, but we're doing it on a hospital ward. And so these are patients that I included in the trial. And, if you have a patient in a monitored setting or a closed unit, I do think it's your judgment as well. So because these are patients that we were doing this on their COVID ward, and these are patients that would often be monitored in a step down unit or something similar, I do think that it's reasonable to consider putting your patient on therapeutic anticoagulation as long as they meet those eligibility criteria and the bleeding risk does not outweigh the benefit of doing that.
Thank you very much. That's very helpful.
You're welcome.
Josée, why don't you ask a few more? I think Mike looks frozen on his screen. So
yeah, I think Mike is frozen. We have a question about you spoke about the half dosing of low molecular weight heparin for the ICU patients. And I have a question that is asking on the evidentiary basis for the use of this kind of intermediate dosing of anticoagulants.
Yes, absolutely. So there is none. This was, I'll be very honest, there is none. So this was based on myself, my colleagues as a group of thrombosis physicians, where we saw this information very early on that despite DVT prophylaxis, rates between 5 and 30% for hospitalized COVID patients were developing DVT and PE. And because of that, we recognize that this is a very prothrombotic viral infection. And if our standard dosing of DVT prophylaxis is not effective, let's try to use an intermediate dose. And again, we had similar criteria evaluating bleeding risk. So patients that were thrombocytopenic, patients with renal dysfunction, those were considerations when making that decision to provide intermediate dose anticoagulation. So again, balancing that risk of thrombosis and bleeding is still important when using even an intermediate dose of DVT prophylaxis.
Thank you very much. I have another one if unless Mike is still frozen.
I think
Go
he's
ahead,
pointing to you.
Josée.
Yeah,
I
go
think
ahead.
Mike is on.
So all right, I'm taking over. There was another question also, the role of a potential ASA or sub-Q anticoagulation for patients that are not sick enough for hospitalization.
Yes, great question. So there are some clinical trials that are happening, being led in the US and the UK, evaluating different antiplatelet and anticoagulant strategies. There's different strategies involving low molecular weight heparin at prophylactic dosing, as well as using some of the direct oral anticoagulants at different strengths, prophylaxis dosing versus treatment dosing. At this time, we are not recommending that outside of a clinical trial. So I don't have specific recommendations for doing so. What I would say is if your patient is already on an anticoagulant for another indication, it would be important for them to remain on it as long as it's safe to do so.
Thank you.
We'll go to Mike in a second. I guess I have a question. The TOSI, do you think that will have any impact on the impact of anticoagulation? I don't have a lot of experience with administering TOSI, but I was wondering if you had any thoughts on that.
Yeah, no, it'll be interesting for sure. I don't have much experience with it either. I think we've had just a couple of patients locally in Ottawa that have received it. And it will be interesting to see if thrombotic rates are as high in patients who don't receive therapeutic anticoagulation as part of their standard of care now. And, you know, it's also interesting to know, does the use of dexamethasone also implicate reduced risk of thrombosis as well from the anti-inflammatory properties that it carries? So I think it's going to be difficult to discern what has the most benefit in patients where they get a combination of these therapies.
Thanks, Lana. I would just ask everyone to do the survey that has been posted by Lisa. So please take the time to do that. Mike, do you have a question or two? And then we'll go back to Josée and we'll have you do closing comments.
Steve, I'm sorry, I'm just having a couple of technical difficulties with the yeah, you know, you're not surprised I'm having technical difficulties. So I can't quite see the chat in the YouTube right at this moment. Lana, I was wondering about whether or not there's, you know, any reason, you know, on the therapeutic anticoagulant side to think that a particular agent, I mean, obviously we're going to use unfractionated heparin for patients with renal failure, but outside of that, you know, are the NOACs helpful in this environment? Is the low molecular weight heparins, is one better than the other as a possibility? Most of us in the, you know, kind of on the ICU side are going to be leaning towards things that we can get out of trouble with quickly.
Yeah, great question.
Yeah.
Yeah, absolutely. So there are some ongoing studies that are, again, looking at direct oral anticoagulant use in this hospitalized population. What we think the benefit from using low molecular weight heparin and unfractionated heparin is also related to their anti-inflammatory properties that they carry. And so we don't know if the direct oral anticoagulants will have a similar impact in that regard. So I would suggest using either a low molecular weight heparin, whether it's enoxaparin, dalteparin, tinzaparin, whatever's available, or unfractionated heparin if your patient has renal failure. I think those are what I would suggest using over using a direct oral anticoagulant right now. Having said that, if your patient is already on a direct oral anticoagulant for atrial fibrillation, for example, I don't think you need to stop their direct oral anticoagulant to put them on low molecular weight heparin. That we don't have enough information to support, so I don't know that you need to make that switch.
That's good.
That's really helpful.
Josée, there's a couple more questions there. Are you able?
Yeah, I have another one here, and I think it relates to clarifying the role of the D-dimers and the trend of the D-dimers. And I think, as you mentioned, we don't know enough as of yet, but if we are trending, a rise may help us be more suspicious of ongoing thrombosis and maybe trigger some testing.
Yeah, exactly. So in the cases that Dave had presented, in the setting of rising D-dimer with a respiratory deterioration, it would make me more likely to go and get imaging for that patient to see if they have pulmonary embolism. Similarly, if the D-dimer is increasing, but you're not seeing a respiratory deterioration, it may simply be the effects of the inflammatory response from COVID itself. So not necessarily that you need to rush off to get a CT scan for your patient, but again, just to have something in the back of your mind as a way of following this. Whereas previously we didn't have any utility for following trends of D-dimers outside of COVID-19.
Thank you very much.
You're welcome.
Josée, one or two more, and then.
Yeah, actually, I would like to ask another question. For the patient population that are actually cardiac and present with cardiac disease in the context of COVID, and they get managed according, to the disease, they go to the cath lab, they get their dual antiplatelets and everything. They also end up in an ICU. So what are your thoughts? Because they do, especially if they have PCI intervention, they are on their dual antiplatelet. So my understanding with this population is we would continue with the dual antiplatelets instead of converting to full anticoagulation and maintaining the usual standard of care.
Yeah, so really important to distinguish that because it's also important to recognize that we're really looking at patients with COVID pneumonia when we're talking about use of therapeutic anticoagulation and not necessarily other manifestations of COVID. So for example, if somebody comes in with the GI symptoms of COVID and they're dehydrated from diarrhea because they've developed that as their principal manifestation of COVID infection, that's not the patient that I put on therapeutic anticoagulation. It's really the patients with pneumonia that we're talking about.
Thank you very much. That's very helpful.
You're welcome.
Dave?
Well, I'm just looking at the time. Is there maybe one more question, Josée, and then we'll go to Mike and we'll.
I'm just looking at the trend of Q&A.
Okay.
And I just have a quick question because when we're measuring D-dimers, often hospitals have a higher threshold where it is above, and then it becomes difficult to trend, actually. You can't trend because it gives you an amount above a certain level. So what are your thoughts on those?
Yeah, so everybody probably has a different D-dimer assay that they're using, and if it's really important to you, you can ask your biochemist to consider diluting it. But I think at that point, if it's read as high or indeterminate, I think the ability to just trend the fact that it's elevated above a certain threshold is probably sufficient.
Thank you.
Thanks.
Great. So thank you, Josée. I'm sorry if we didn't get to everyone's question. Certainly, it's always good to hear from it. And I'm going to go to Mike for final words. But thank you again, Lana. Always a pleasure to hear you speak.
Thanks.
Lana, this was terrific. Thanks so much for really a great presentation. It's kind of exciting to be, this close to the science of what's going on. Dave, Josée, I'm really struck by the connection to our last webinar about about all of our ICUs participating. This is a tremendous example of how important it is for us to ask questions and to participate in the answers.
Mm-hmm.
We've just got this natural belief, or would have had this natural belief based on some information coming out of New York, and I think just our general orientation around the fact that, well, if we've got a therapy and somebody's sicker, then obviously they need the therapy more than the people who aren't as sick, right? And so it would be natural for us to have been willing to anticoagulate all of our ICU patients, the ones who were among the sickest, and to be less active about working on the patients who were perhaps in an intermediate level of sickness. And this, what's happened here, this 4-platform collaboration in order to be able to generate enough patients to actually get to an answer in a very short period of time that was material for the folks who are listening to this webinar. In terms of being able to not harm their patients and to provide care to the patients who need care. It's just a tremendous, really tremendous thing. And thanks so much for bringing all of that to us, Lana. I will remind folks that the recording of our last webinar about participation of all of our ICUs in the scientific endeavor is available on YouTube, as are all of our other previous webinars. And we have our next webinar scheduled for March 4th. I'm remembering that now correctly, and it will be on HHR. And really, I think the whole business of how we're kind of dealing with this pandemic from a staff response standpoint. So Dave, I think we'll close there. Lana, again, thanks so much. Really, really wonderful presentation. And
Thanks.
Goodbye to all of you folks who've joined.
Thanks.
Thank you, everyone. Thank you, Lana.